2-minute anaesthesia preoperative assessment. The National Audit Project 4 by the RCOA identified clear outcomes. Poor airway assessment contributed to poor airway outcome. There was inappropriate use of supraglottic airway devices, and aspiration was the single commonest cause of death in anaesthesia, and 25% of major airway events occurred outside of theatre. Therefore, adequate airway assessment is essential. Perioperative assessment includes multiple facets. Today we'll focus on history and examination. An anaesthetic history is based on a standard medical history with additional anaesthetic components. History presenting complaint of the disease pathology and related complications may indicate the urgency of the procedure. The past medical history, family history focused on inherited diseases, for example MH, Sucks apnea and porphyria. Social history, smoking, alcohol and illicit drugs. Drug history including allergies and important agents, anticoagulants, antihyperglycemics and cardiorespiratory drugs. If indicated, perform a systematic inquiry. Then, an anaesthetic history of previous anaesthetics and include intubation grades if you can observe them in the patient's notes and related complications. Gastroesophageal reflux disease, the timing of oral intake, food and liquid, recent ongoing infections and steroid use, cardiorespiratory function and related chest pain. Following the history, perform an examination. All patients should have a documented weight and height leading to a BMI assessment. Also determine the observations of heart rate, temperature, respiratory rate, blood pressure and saturations. If indicated, a blood sugar. Perform an airway assessment and based on the patient's age, history and clinical features, perform, if indicated, cardiorespiratory and gastrointestinal examinations. Airway assessment can be general and specific. General, observe the patient. Determine the BMI, neck and facial pathologies and related syndromes. Specific, assess the patient's mouth opening, observe the teeth and determine the Mallampati score. If there's an obvious airway pathology, palpate the airway. Assess movement, neck flexion, jaw protrusion, thyromental and sternomental distances. The figures in red are associated with a difficult intubation. The Mallampati score has a direct association with the intubation grade. Ask the patient to open the mouth and stick out the tongue and observe the back of the mouth. There's 4 different subtypes. 4. All you can observe is the hard palate. 3. You can see the base of the uvula in addition to the hard palate. 2. You can see the full uvula. And 1. You can see the full uvula and also the tonsillar pillars. Once you have completed your history and examination, it's important to highlight risk factors for difficult mask ventilation. These can be acute or chronic. Acute could be laryngospasm, bronchospasm, foreign body pneumothorax, bronchopleural fistula, and chronic raised BMI, high Mallampati score, beard, no teeth, and increased soft tissue of the tongue or epiglottis. Risk factors for difficult intubation can be acute or chronic. Acute, for example, tumours, infection. Chronic, for example, a history of previous difficult intubation, raised BMI, an examination of reduced mouth opening, large tongue from Down syndrome or glycogen storage disorders, and jaw pathology, so receding jaw or reduced jaw protrusion. In addition to reduced neck flexion, for example, rheumatoid arthritis, angstbond, and also airway pathologies, P.O.Raban, goiters, and radiation. There are multiple scoring systems to suggest a difficult intubation. Here are 2. Wilson score. Based out of 5 factors, each is scored out as 0 to 2. 2 to 3 points suggest a 75% sensitivity of a difficult intubation. The Mucker score. This is spaced out at 12. 0 is easy, 12 is very difficult. And can be submitted to patient, situational and operational factors. Operational factors include non-anaesthetists performing the intubation. It's important to recognise an airway obstruction. This can be done on a history and examination. History, 4 Ds and positional symptoms. The 4 Ds include dysphagia, dysphonia, dyspnea and drooling, and an examination assessing the effectiveness, the effort and the efficacy of airway movement. Please like and subscribe.